Hi everybody, my name is Mohammed Saad. I'm going to discuss an article with you today. Introduction on the article is beginning with the title. The study was called Measuring the Impact of a 3D Simulation Experience on Nursing Students. Also, Cultural Empathy using a modified version of a Kismet-Chen Empathy Scale by Naila Eversion et al. This article is very interesting because it relates to the concept of empathy, specifically cultural empathy, discussed throughout the course, and how it is experienced by culturally and linguistically diverse patients. Those will be deemed throughout the study as the called patients. Throughout the course, we have addressed the healthcare communication problem among patients with illiteracy and healthcare providers as well. In this article, we're taking a closer examination of this problem. I'd like to start this presentation by providing some background information on why cultural empathy is crucial in healthcare management, especially amongst culturally and linguistically diverse patients, the called patients. So this is based on evidence from scientific studies. Fact number one, migrant populations due to accelerated globalization in the last few decades increased by 4 times in Western countries, according to Alonso et al. In 2011. Fact number two, called patients experience higher rates of adverse health effects than English-speaking patients because of miscommunication and misunderstanding. Number three, marked health inequalities are seen in elevated mortality and morbidity seen in the United States, according to Anderson and Olson in 2013. Number four, in the United States, hospitalized patients with English deficiency experience twice as many adverse events as compared to English-speaking patients, according to Divi et al. In 2007. Number 5, fewer diagnostic tests were ordered and performed on called patients, according to Horner et al. In 2004. Number 6, incorrect surgeries and misdiagnosis occurred more in called patients, according to Johnson and Kantinsky in 2006. Number 7, called patients have higher rates of depression, fear, and loneliness, and are less likely to seek treatment. This is according to Sumanth and Cooper in 2008. Number 9, and the last one, is the fact that says that health professionals are less likely to show empathy to called patients, according to Sumanth and Cooper, published in 2008. Now I would like to provide information on the participants in the study and the study structure, along with the methods, results, and discussion, and so forth. The participants were a total number of participants of 460. They were all recruited from Blackboard from one university in Australia. They were all second-year undergrad nursing students with an average age of 27 years old, 27.5 years old, with a standard deviation of around 8 years. 88% of the participants were female. Second fact is, with respect to the methodology, the researchers of this article designated a one-group pre-test, post-test design, a 3D experimental simulation by means of watching a 3D 10-minute videos were conducted on the participants and exposed them to an unfolding scene in a hospital ward of a developing country in which the environment, language, and culture were very different from the Australian culture. The participants were asked to take a modified Kismet-Chen Empathy Scale before and after the simulation. So in other words, they were pulling the participants into a simulated scenario where they were in a less privileged healthcare setting, and they were trying to see if this would change their empathy using the scale pre and post the simulation. The scale consisted of 8 questions and comments that measure cognitive and affective empathy on a point scale of 1 to 7, 7 being strongly agree. Example questions included things like, I'm able to express my understanding of someone's feeling in a better way, and I believe caring is essential to building a strong relationship with patients. Scores were then obtained and calculated the sum of the individual items on the scale. Higher scores indicated higher levels of empathy. Pre and post simulation scores were analyzed using a t-test and SPSS scales. Results in the research study reported that participants reported significantly higher means of empathy post-simulation by 49.24 compared to pre-simulation of 47.86. P-value was less than 0.001, so the results were valid. A 3D cultural simulation had a profound effect on participants' cultural empathy scores. This simulation can therefore serve as an effective educational intervention that increases empathy and consequently promote health professional students. Cultural competence, cultural empathy can reduce the possibly eliminate prejudice experienced by our called patients. Next, I would like to address some of the weaknesses in the study. There have been some gender bias with the fact that 88% of the study participants were females. There has been a limitation on the age group that participated in the study, being strictly nursing students around the age of 27.5 years old. The participants in the study were from the same cohort, being participated from the same university. The scale used in the study seemed very limited because it only consisted of 8 questions to cover the empathy aspects. Furthermore, I would like to provide some insightful questions that could be an opening for further discussions. First question is, the study was significant, showing an immediate change in empathy scores between pre and post simulation, but how sustainable could these results be over a longer period of time? Also, what could be other factors involved that would affect the sustainability of those good outcomes and good results? Second question, do you think that experimental 3D simulation conducted in the study is just effective to yield reliable results regarding empathy towards called patients as you would use a real or actual experience in a hospital setting? Question number 3, why would you feel more empathy towards people who are more like us than towards people who are different from us, if that's at all true? Now, if this is true, does this explain why we are affected more emotionally by tragedies happening in our country than others that are happening in different countries? Question number 4, as a healthcare manager, would you invest in a 3D simulation educational strategy amongst nurses with the goal of increasing cultural empathy, or you don't think it's a feasible tool? Question number 5, and the last question, does our society suffer from an empathy deficiency epidemic, and it's just manifested in the healthcare setting? And where do you think empathy comes from? Do you think it's acquirable? Do you think it's perishable? And what are we lacking to have healthcare empathy? Is it a spiritual drive or a self-monitoring tool or anything else? Finally, I would like to finish the presentation with a brief conclusion. To conclude, the purpose of the study was to create an authentic simulated experience of the participants that resembles that of a patient receiving healthcare in a novel setting completely different from their own culture. The study did reach that goal, and the participants reflected on their experiences during the debriefing stage of the experiment. After post-simulation, the level of cultural empathy significantly increased. This study gives promising results that could be used to help create healthcare equality in the United States and elsewhere in the world. Thank you very much.